Well, yeah, okay.
Just one.
This is Kim. Thanks. You guys can see it, right? Screw it up this time. All right, nice job.
Okay, so this is a 32-year-old female, no visual complaints, no real medical history, no medications. She is 20/20, and her pressures are maybe a little elevated on the right, but otherwise pretty normal. Here we go.
All right, so this is a color fundus photo of the right eye. Vitreous is media is clear, the nerve looks pink, sharp, and flat. Vessels look pretty normal in caliper. Maybe a little bit of sheen, and or just like reflections in the
Sheen of
superior cape, but overall looks grossly normal.
That's what Dr. Bowie calls it, the sheen of youth. Is that what you guys call it?
Oh, no, I haven't heard that. Who calls it that? I like that.
I thought it was funny. That was like something she told me the first week of ophthalmology residency. So I was like, what is all that?
Everything's a little prettier.
Yeah.
Yeah.
Gravity, yes.
Kind of largely the same thing here, color fundus photo of the left eye. Media is clear, nerve is pink, sharp, and flat. It's the same sort of sheen along the arcades. Macular looks relatively normal.
Nice.
Okay, so this is also color fundus photo of the left eye, but farther out in the periphery temporally. There's a pretty large hyperpigmented lesion, maybe 3 or 4 disc diameters. Kind of hard, it appears elevated. I'm trying to trace the vessels. I can still see them underneath.
I think there's a close-up, isn't it?
Yeah. Yeah.
Okay.
So if it's pigmented, but you can still see the vessels.
So then it's underneath the vessels, right? So it's subretinal.
And then what did you say what color it was?
It's dark, like kind of black with some like grayish pigment around the periphery. It looks like there's drusen within it too, like some yellowish deposits.
And then are the margins sharp or blurred?
I think the margins are pretty sharp.
They're pretty sharp. And then there's nothing around. I'm trying to remember, ICML has these 7 characteristics. They're on the website.
It's like the
Size,
component.
color,
Yeah.
location, company it keeps, the margins.
The company again.
Yeah.
I think you said like fluid or not.
Yeah.
Stuff like that.
Yeah.
And then Dr. Pavin has the thing, I don't know if you're still there on when you say elevated or not by 2 DQs or some way you say it. He says it, but whether it's
you really can't, you do it by visual clues, but you can't without stereo know whether it's really elevated or not.
Right.
One of the things about the older cameras that I was raised on is they have extremely shallow depth of field. So you could tell if something was in focus and then something else like an elevated on the surface of an elevated tumor, it would be out of focus. And that was a big clue. And the course of the vessels, this lesion is probably actually has, I would guess it's going to maybe show a millimeter up to a millimeter of elevation, but it's like what do you call it, mesa or mesa in the Southwest?
Oh yeah. Mesa.
How do you say that? I'm a gringo, so I don't know how to say it. But
it just means table.
oh, does it?
Yeah, in Spanish.
Oh,
Yeah.
how do you say it?
Mesa.
Mesa. It, as you know, as opposed to a rolling hill in South Dakota. So like more melanoma. Okay. So yeah.
So there's that dark spot in the middle. It's not very purple.
Yeah, autofluorescence of the right eye. Yeah, you see that central hypopigmented autofluorescence looks largely normal. Same Same thing here with the left eye. This is a OCT horizontal of the right eye. Looks largely normal to me. The organization looks normal. I don't see any drusen, no fluid. Same thing of the left eye. Nothing particularly draws my attention.
You guys remember all the layers, not the harass you too much, those 4 outer layers? Cool.
Of the outer?
Yeah,
outer
4
layers?
bands. Like there's this one here, what's that light one?
That's the external limiting member.
Good, and then that one,
And that's the ellipsoid zone.
perfect, and then these kind of 2
That's
down
like
here.
the ISOS junction, or the interdigitation zone,
Perfect.
and then the RPE.
Nice.
Nice.
Wow.
So nice.
It's a, I forget what, an IR, I forget what this one's called.
Infrared.
Infrared photo? Okay.
Yeah.
Of that lesion we were seeing in the left eye. I forget how to describe the.
You can do reflective.
Okay, so let's say the lesion appears hypo-reflective, well demarcated with kind of scattered areas of hyper-reflectivity and hypo-reflectivity within it. Great. This is an FA of the right eye.
Yep, and I'll click through it. I forgot how many there are. Okay, cool. You get 2.
Okay, I don't see like any apparent like leakage or pooling, vessels all look filled.
Yeah, that's the main point, that it's basically progressed all the way through to like, and it's not really seeing that much. This is left eye.
Left eye, this looks like this, that area of the lesion we were looking at.
So that first phase where you don't see the vessels, you just see the, what is that one? Do we have a name for that one?
I don't remember.
Not the choroidal, Right, and then what's the next one? So if you go next 5, you get the,
You starting the like arterial
good,
and. So,
The same muscle.
yeah, so you have some hyperfluorescence within the lesion. I wouldn't really say it's leaking.
Yeah.
They seem to kind of fill and see their overall,
Yeah.
the lesion is.
The
looks like
lesion
a
itself
window
is
or
not, yeah.
blocking.
I agree with you, that the
Makes sense.
lesion itself is pretty well circumscribed, doesn't look like it's leaking anywhere from it, maybe just filling little spaces in there, or a little leakage from that one little area.
so that'd be like a window defect.
Window.
And if you see it that early, there's a famous, I think maybe passed away, did Howard Schatz die? He had a book on fluorescein angiography. I heard him lecture when I was your age a long time ago. And he talked about intravascular and extravascular. So he would say the early fluorescein is the intravascular phase, the late one's the extravascular phase. So this showed up at like 0.
Yeah.
So that means it was, no fluorescein leaked out of anything. So all you're doing is you're seeing fluorescein you're not supposed to see, or you're not seeing fluorescein you're supposed to see. So there's a contrast. So the dark lesion's probably blocking more, and then that little area is letting it through. In fact, if you look at the rest of it, it's almost like that area looks about the same as the rest.
Yeah,
Yeah.
So it's probably that you're seeing the,
everywhere else is blocking
blocking.
except for,
so there's a window.
The window. but good, you said that's not leaking in your,
Yeah.
okay,
This is a B scan.
I'm not sure what that is.
I guess, no, I'm not sure either, but.
So what can you tell, like the printed negative?
pertinent negative is that there's no, like hollow mass.
Yeah, good. There's no like elevated lesion, there's no like mass filled with fluid, no dome shaped anything. Oh, do you want to, I summarized the findings for you. But do you have anything to add to that? Basically, yeah, exactly what you said. There's this large pigmented subretinal peripheral lesion, no associated fluid, heme, no sentinel vessel. And you also said a lot of good things, like there maybe are a little, maybe drusen, maybe not, but there's no fluid surrounding. And then you said no leakage on FA, it was not elevated on B scan, and then there was no fluid on the OCT map. So what's your differential?
So top differential would be like a choroidal nevus versus a melanoma. Other pigmented areas, could just be RPE changes, could be atrophy, but definitely thinking nevus and melanoma.
What's the one that if it's like right next to the nerve and it's super dark? Maybe it wasn't this year, someone had one like.
We had one, but it didn't look like that. That's why those are, I hardly ever see those. The melanocytomas. Could be.
And they're super dark.
They're super dark.
They're usually like right attached to the nerve,
Not
never
super
even
common.
think.
This lesion's pretty common.
So yeah, this is it's very similar differential. I did include torpedo maculopathy because I randomly wrote a paper on it. I think it's like the only paper that exists because it's such a random diagnosis. It's just like a pigmented lesion that looks like a torpedo and it's benign and non-progressive. Just wanted to shout out that. But yeah, so choroidal melanoma is a thing you want to not miss, of course, and you give a lot of pertinent negatives, just a benign nevus, metastasis, if there were a bunch of them and she had a history of melanoma somewhere else, just a focal pigmentation, like you said, and then CHRPE, which what is this? So this is a congenital hamartoma of the RPE. It can be, there's different types of them. It can be a solitary lesion like this one. It can be grouped, and we think this is like the bear tracks is the buzzword for it. Or you can have an atypical one. The atypical one is more, it has like a different shape in it, is more, I'll show you a picture. And that's the one that's associated, like we learned in med school, with familial adenomatous polyposis or FAP. That is like, it's in about 1% of the population, so it is not uncommon, and it's a clinical diagnosis.
Now, I always thought the H was hypertrophy, not hamartoma. Is it now hamartoma?
I'll double check, but
It's hyper.
what?
Okay.
What did I
But
get?
I think she's saying.
No, she wrote hamartoma.
Okay, maybe
Get
it,
that? Okay.
yeah.
I agree with you. I agree with you,
Yeah,
Steve.
it is hypertrophy.
Okay, so congenital hypertrophy.
Yeah, forget that was during the hurricane, so just forget that. I was thinking
Well, because sometimes stuff changes, yeah. It's possible somebody changed it.
So this is what I was talking about. There's different groups of it. So there's solitary, which is more similar to the one that we saw here. There's grouped, which it kind of does look like bear tracks, that you can see looks like little paw prints. And then there's the atypical. You can see like the shape is a little bit weirder. It's more, I guess it is more torpedo-like, but then there's can be clumps of them. So the thing that you want to not miss with CHRPE is that there's association with FAP. So this, I think we do get tested on. So I think it's high yield to know about. So I was just going to go a little bit more into it. So this is autosomal dominant. They love to test on the inheritance. It has to do with the APC gene mutation. You get a lot of polyps in the rectum and colon, and it's associated with the atypical CHRPE. So it's they're a little bit smaller, as you can see, compared to the solitary one that we saw here. They're like 50 to 100 microns. And they are a screening marker for FAP, but the absence of them does not rule out FAP. So if you see a bunch of them, then you should probably make sure that the patient is getting screened for FAP. So then there's also a couple FAP plus syndrome, basically. So there's Gardner syndrome, which is all of this plus skeletal hamartomas and then various soft tissue tumors. And then there's also Turcotte syndrome, which is FAP plus brain tumors, which is definitely like, you don't want to miss that one. So if you have enough suspicion for like atypical CHRPE, then you should definitely be communicating with primary care that there, I don't know, do you guys do that, or how do you normally?
The way I handle is the inheritance is so strong.
Yeah,
In the absence of a family history with a solitary CHRPE, I wouldn't do that.
yeah,
But if there's a family history, you always say you have a family history of polyps and
Yeah.
colon cancer. And if it is something, you'll typically hear, oh yeah,
yeah.
you know, 3 family relatives are dead from colon cancer.
Yeah. Cause it's also maybe some family members who had it didn't get like detailed peripheral retinal examinations, so they might have just missed it, cause it's doesn't really affect your vision at all. Other than, so for management, so typically observation, they can enlarge over a 3-year period, but it's usually of no consequence, like because it's so peripheral. It doesn't typically affect acuity unless there's foveal extension of the lesion for some reason. And then I saw occasionally it can be associated with a CRSRD. I don't know how much you see that in practice. I've never really heard of it, but I'm not a specialist. And then it said rarely you can get CNB, rarely you can get CNB, but largely benign, and not really sort of progressive. Yeah, any questions?
What differentiates a nevus from solitary?
That was my question.
Yeah, I also wasn't quite sure, other than like the hypertrophy itself, because the nevus is just in the choroid versus it's basically like RPE
They just look
hypertrophy, so it's just a
clinically
layer of it.
They
But-
look clinically.
But they
different.
look, one's a little bit less
Nevus
sharp.
doesn't have, the borders are not as sharp.
Okay.
They're more of a.
They look very flat too, like.
Yeah, nevus, yeah, they're flat. They're more of a brownish color usually, unless they're melanoma, instead of that dark black gray color. And yeah, these tend to be a little bit thick, where nevi nevi can be thick too, but typically if you, typical nevus is pretty flat. You don't usually see drusen with this, with the nevus you do. You see lacuna, and I think that's maybe older patients, they'll start to thin out. And so sometimes these CHRPEs can be very light because there's so much thinning in the center, but you can see the very border will still be pretty black and it's like.
Reed, how's that? Reed's our pigmented.
That sounds great. That sounds right on.
Thank you. So yeah, they just look different. And they really do, they look a lot different. When you see enough.
You'll
Looks like
get
a
a lot
freckle.
of consult if you're retina from optometrists thinking that's the nevus all the time. So it is good to know that distinction.
And I don't follow. So it's like,
I don't, I'll take a picture and I just say, I'll get a baseline, go back to your primary eye doctor. If I ever see you again, we'll take another picture. I don't follow them typically. But a lot of times it's an incidental finding, so you might be seeing for something else.
do you have patients take pictures of the pictures? I do that all the time.
Sometimes,
Yeah.
like, look at pictures of their OCT, like, look.
Yeah, I have, like, if I have a pigmented lesion, I'll have them take a picture of the picture. It's helped me before, because sometimes our database, not often, I think twice, we've lost images in our database.